Okay, so again, welcome to the Orlando GI Journal Club, coming from Orlando, Florida, February 1st, 2023. Our first study was published in the Red Journal by Im et al. This is a study looking at response-guided therapy with cefotaxime, ceftriaxone, or ciprofloxacin for spontaneous bacterial peritonitis. This was a randomized trial. So this study is important in our clinical practice because SBP is a serious complication of cirrhosis, and the mainstay of treatment is antibiotics. And several antibiotics are currently recommended by the guidelines, cefotaxime being the most recommended by the guidelines with ceftriaxone and ciprofloxacin. However, it is unclear whether these antibiotics are comparable. The ASLD guidelines recommend empirical antibiotics in cirrhotic patients with acidic fluid PMN count of greater than 250 per millimeter cubed in absence of broad spectrum antibiotic exposure in a community setting. So the aim of this randomized trial was to evaluate the current efficacy of empirical antibiotics under response-guided therapy in SBP by comparing three commonly used drugs: cefotaxime, ceftriaxone, and ciprofloxacin. So this was an open-label randomized trial conducted in South Korea in 9 tertiary centers. They included all patients aged 16 to 75 years with cirrhosis and ascites with PMN count of greater than 250 cells per millimeter cubed. And what they wanted to do was do a response-based therapy, which means that after patients were randomized to one of the three antibiotics, cefotaxime, ceftriaxone, or ciprofloxacin, they performed a follow-up paracentesis at 48 hours to look at the PMN count to see if it was reduced by more than 25%. If it had, then they would continue, and then they would repeat paracentesis at 120 hours, which is 5 days. And if it was, had reached that goal, then they would assume resolution of SBP, and then they would switch to oral quinolone and follow up at 4 weeks to assess recurrence rate and mortality. If PMN reduction of greater than 25% was not reached at 48 hours, they would change the antibiotic agent to a more broad spectrum antibiotic, and then again follow with a paracentesis at 5 days and then look at response. The primary outcome was SPB resolution at 5 days, 120 hours. And they defined resolution of SBP as fulfilling all of these conditions: a decrease in PMN cell count to less than 250 per millimeter cubed, normalization of leukocytosis in peripheral blood, no bacterial growth either in peripheral blood or acidic fluid culture, and resolution of symptoms that the patients originally presented with, which were usually abdominal pain and fever. So these were the baseline characteristics. A total of 261 patients were randomized, 87 to cefotaxime, 87 to ceftriaxone, and 87 to ciprofloxacin. And as you can see, the baseline characteristics are similar between the two groups. The main variable that was significant was the acidic fluid, white cell count, the acidic fluid, PMN, and as you can see, the total, the mean acidic fluid PMN count was over 2,000. So when they looked at the rates of resolution of SBP, which was the primary outcome measure, at both 5 days and 7 days post treatment initiation, they found no significant difference between the three types of antibiotics, with p-value of 0.388 on intention to treat analysis. At 7 days, they also found no significant difference between the three types of antibiotics, with p-value of 0.725. When they looked at the type of cultured bacteria from the acidic fluid or blood, the most commonly cultured bacteria was E. coli at 34%, followed by Klebsiella, and then Streptococcus. The more rare organisms cultured were Staphylococcus, Aeromonas, Acinetobacter, Bacteroides, Bacillus, and then Enterococcus. When they looked at survival rate at follow-up at 1 month, they found no significant difference between the 3 types of antibiotics, cefotaxime, ceftriaxone, and ciprofloxacin, with p-value of 0.770 on log rank test. When they also looked at factors associated with survival on multivariable analysis, they found that the factors associated with survival in patients with SBP in the study was bilirubin and albumin only. Actually, leukocyte count and PT-INR did not light up on this regression analysis. The main limitations of the study is the short follow-up period of only 30 days. Also, the study was conducted over 11 years, and therefore the authors do state that the antibiotic sensitivity may have changed during the course of the study. Also, there's a low rate of positive bacterial culture in the study, and therefore there's limited data on the possible changing patterns of antibiotic resistance, and it was not something they could really investigate in detail in this study. So the main take-home points from this study is that the efficacy of empirical antibiotics, cefotaxime, ceftriaxone, and ciprofloxacin against SBP was not significantly different, and ceftriaxone and ciprofloxacin were not inferior to cefotaxime, which is the current standard for empirical therapy for community-acquired SBP. With increasing prevalence of antibiotic-resistant organisms, response-guided therapy, as these authors did in this randomized trial, where they consider the results of a 48-hour acidic PMN count on paracentesis, ensures the safety of empirical antibiotic therapy. Our next study was by Denise et al. This was published in the Red Journal this month. This is looking at the efficacy of filgotinib on the rapid and sustained symptom relief in patients with moderately severe or severe ulcerative colitis. And this was a post-hoc analysis data from the phase 2b/3 selection randomized trial. This study is important in our clinical practice because in patients undergoing treatment for ulcerative colitis, rapid onset of action is one of the most important aspects of treatment. Filgotinib is a once daily oral Janus kinase 1 preferential inhibitor. And post-hoc analysis to assess the rapidity and sustainability response to filgotinib was important. And this was done using data from the selection trial by examining patient-reported UC symptoms and partial Mayo clinical scores. So this was a post-hoc analysis of the data from selection trial. This was a phase 2b/3 double-blinded randomized placebo-controlled trial, which consisted of 2 phases: the induction phase and maintenance phase. The induction phase consisted of 2 cohorts. One was the biological need, one included just biologic naive patients, and the second group included biologic exposed patients. And basically what they wanted to do was, in the induction period, patients with UC were randomized in a 2:1 ratio to filgotinib dose 200 milligrams, 100 milligrams, or placebo, and they were undergoing this treatment for 11 weeks. At the end of the 11-week period, so at week 10, they looked at which patients had achieved clinical remission or partial Mayo clinical score response. And then these patients were then randomized to, in a 2:1 ratio at week 11 to filgotinib at the induction regime or placebo. And the patients in the maintenance study were followed through and received treatment until week 58. The authors specifically in the post-hoc analysis wanted to look to see how fast the patients were able to achieve symptom relief by evaluating rectal bleeding and stool frequency subscores on days 1 to 15. So when they looked at rectal bleeding and stool frequency subscores between days 1 and 15, they were able to get this data on 659 biologic naive and 689 biologic experienced patients in the induction studies A and B. And they were able to have data for analysis on 320 biologic naive and 238 biologic experienced patients in the maintenance phase. And as you can see, all these asterisks here represent significant p-value. 1 asterisk is p-value of less than 0.05. 2 asterisks are p-value less than 0.01, and 3 little stars are p-value less than 0.001. And they were comparing the response in patients receiving filgotinib 200 milligram dose Q daily versus placebo. And as you can see, when they were looking at biologic naive and biologic experienced patients, that the symptom relief achieved was significantly higher in the filgotinib group compared to the placebo across pretty much all of the follow-up period of 15 days when they looked at rectal bleeding and also stool frequency subscores. When they looked at the rectal bleeding subscore and stool frequency subscore combined, again, filgotinib was superior to placebo over the follow-up of period of 15 days while receiving this treatment. The authors then looked at partial Mayo Clinical Score remission and response. And as you can see, again, if you look at this blue line is filgotinib 200 milligram. This orange is filgotinib 100 milligram dose, and the gray line is the placebo. And when you're looking at remission, according to the partial Mayo Clinical Score, filgotinib was superior to placebo. Also, when looking at the response rate, according to the partial Mayo Clinical Score, again, filgotinib was superior to placebo. The authors then also looked at the proportion of patients who in the maintenance phase had response to filgotinib and a placebo. And as you can see, when they looked at response over time, again, filgotinib was superior to placebo in the remission and response phase of the maintenance study when they followed the patients through up to 58 weeks. The main limitation of this study is that patient population was specifically chosen to enter into the maintenance phase, and use of patient-reported outcomes were utilized in the study to assess the rapidity of response. And so certain symptoms such as urgency were not evaluated. Also, biomarkers were not measured within the first 2 weeks in the selection trial, and therefore data regarding response to biomarkers when using this treatment is limited. So the main take-home point is that once daily filgotinib 200 milligram improved patient-reported outcomes within 7 days of treatment initiation in biologic naive and biologic experienced patients with moderate to moderately severe active UC. Over half of biologic naive patients were in remission by the end of induction, and the beneficial treatment effect of filgotinib 200 milligrams on UC symptoms was maintained in a high proportion of patients until 58 weeks of study. Filgotinib appears to be a valuable treatment option for rapid and maintained relief of UC symptoms. The next study is looking at liquid biopsy for the diagnosis of NASH and liver fibrosis. This was published in GARD. So diagnosis of NASH currently relies on invasive liver biopsy, and these authors wanted to see if it was possible to identify non-invasive biomarkers for NASH diagnosis, disease progression, and intervention response monitoring. Hepatic macrophages include not only resident Kupffer cells, but also monocyte-derived macrophages. And it has been suggested that as far as NASH progresses, Kupffer cells are replaced by these macrophages, these monocyte-derived macrophages. And then these monocyte-derived macrophages are reprogrammed or repolarized in the liver towards a pro-inflammatory and pathological phenotype, acquiring a foamy phenotype, and then they re-enter the circulatory system from the liver. So the authors wanted to look at the accuracy of two monocyte proteins, perilipin-2 levels in circulating monocytes, and also RAB14 in circulating monocytes as predicted of liver fibrosis. So this study was conducted in 250 patients with histologically proven non-alcoholic fatty liver disease or actual NASH with or without fibrosis. The study comprised 100 patients in the discovery cohort and 150 patients in the validation cohort. And the proteomics were performed in monocytes and hepatic stellate cells, and then flow cytometry were measured in perilipin-2 and RAB14 in levels in peripheral blood monocytes, and they performed logistic regression analysis to measure accuracy of predicting liver fibrosis. So just to summarize, when they looked at PLIN2, they did find that it was accurate for predicting the absence and presence of NASH with area under curve that was very high of 97.8% in the discovery cohort and 97.6% in the validation cohort. Sorry, yes, and oops. And when they looked at PLIN2 for predicting NASH severity, they also found high areas under the curve of basically exceeding 97% for score less than 3 and severity less than 3, and 97.6% for greater than 4. When they also looked at RAB14 for diagnostic performance for presence or absence of NASH, again, area under the curve was very high at 95.9%. And they used this algorithm incorporating RAB14 levels, age, waist circumference, HDL cholesterol, plastic glucose, and ALT to predict presence of liver fibrosis. So because this is a kind of concept study, mainly for randomized trials and study patients, I think clinical value at this point is going to be limited, but it's very exciting and novel development in the world of hepatology. And because it appears that the circulating proteins, PLIN2 and RAB14, were sensitive and specific in diagnosing the presence and severity of NASH and or liver fibrosis, and have the potential to replace invasive liver biopsy-based histology for the diagnosis of NASH and or liver fibrosis. A final study is looking at clinical prediction models of pancreatic cancer in general and that at-risk populations. This is a systematic review by Santos et al. Population-based asymptomatic pancreatic cancer screening is currently not in place and is not considered to be cost-effective because of low incidence, but screening within high-risk populations could be preferable. So this includes patients with family history of pancreatic cancer, certain germline mutations, cystic lesions in the pancreas, new onset diabetes, and post-pancreatitis diabetes. The clinical risk prediction models based on these risk factors could aid the identification of high-risk patients for pancreatic cancer screening. And the aim of this systematic review was to summarize existing literature on pancreatic risk prediction models based on clinical risk factors. So this was a systematic review. They looked at Medline, Embase, and Web of Science databases to look for relevant articles up to November 2021. They looked at 33 studies, and these were finally included which reported on the statistics on predictive performance of risk prediction models incorporating clinical risk factors assessed through questionnaires, interviews, and through parametric measurements or review of clinical records in pancreatic cancer. And they looked at studies which looked at the development of pancreatic cancer, either adenocarcinoma or neuroendocrine tumor. So in the systematic review, they included 33 studies comprising over 15 million participants, of which 58,313 patients were diagnosed with pancreatic cancer. 14 studies described risk prediction models in the general population. 8 studies looked at patients with diabetes and 11 studies in symptomatic patients. Commonly used clinical risk factors were in the model, such as cigarette smoking, age, history of diabetes, chronic pancreatitis, and BMI. And the C statistic, which basically tells you how accurate that model is predicting your outcome measure, which is pancreatic cancer in this case, were varied, ranging from 0.61 to 0.98. But as you can see, it is reasonable if you take the cutoff of 0.7 as being the kind of the cutoff for a good model. 6 studies in this systematic review also had low risk of bias. The main limitation of systematic review is that studies with incomplete reporting of data may have been included, and also studies assessing multiple cancers may have been missed in the systematic review. Pancreatic cancer was not included in the abstract because that was part of the search process to find these studies. So the take-home point is that clinical risk prediction models do exist for pancreatic cancer, developed for different target population. And although low risk of bias studies will identify, these require external validation and implementation studies. So to recap, efficacy of empirical antibiotics, cefotaxime, ceftriaxone, and ciprofloxacin against SBP was not significantly different, and ceftriaxone and ciprofloxacin were not inferior to cefotaxime, which is the current standard for empirical therapy for community-acquired SBP. Once daily filgotinib at dose of 200 milligrams q daily improved patient-reported outcomes within 7 days of treatment initiation in biologic naive and biologic experienced patients with moderate to severe active UC, and over half of biologic naive patients were in Mayo's clinical score remission by the end of induction, and the beneficial treatment effect of filgotinib on UC symptoms was maintained in a high proportion of patients who continued until the end of the 58-week study. Filgotinib appears to be a valuable treatment option for rapid and maintained relief of UC symptoms. PLIN2 and RAD14, which are contained within monocytes circulating in the peripheral blood, was sensitive and specific in diagnosing the presence and severity of NASH and or liver fibrosis, and have the potential to replace invasive liver biopsy-based histology for the diagnosis of NASH and or liver fibrosis. Lastly, clinical risk prediction models do exist for pancreatic cancer, developed for different target population, and they did have a varied but high C statistic. And although low risk bias of studies were also identified, these do require external validation and implementation studies. So this is the end of our journal club for this month. Our next journal club is March 1st, 2023. Thank you so much for joining us today. I hope everyone has a wonderful day and month, and I'll see you in March. Thank you so much.